just mention that we have a section in our division which is called quantitative health, and many researchers like Dr. Shao work on artificial intelligence and related science to it. So today, Dr. Shao, one of our research faculty, is going to tell us about deep learning in medical imaging. Thank you very much, Dr. Shao. We are all ears.
Yeah, thank you, Dr. Kazari, for the introduction. So for today, I will briefly give a brief introduction of medical image analysis, deep learning, and I will discuss a few selected studies from my lab publishing this year and other papers under review, and hopefully to give you an idea, of different kinds of AI research in my lab and what we can do with AI and imaging to help to improve disease diagnosis, treatment planning, etc. And this is an outline of today's talk. First, I'll give you a brief introduction of medical image analysis. And for each medical image analysis task, I will give you one example of our work in clinics. And then I will briefly walk through the idea of convolutional neural networks, which is widely used for image analysis and medical, image processing. And then I will directly go through a few studies. I think I have 6 studies from a lab. And so I won't dive too deeper into the methods, but just show you, what we can do, some background and some results and some discussion. All right. First, the first medical image analysis task I'm going to discuss is image classification. The task of image classification is that you have input an entire image and you want to assign a class label to it. And in other words, you fit in your entire image into some AI model, and the model should output the probability of this image belong to different classes. Say for this image, the probability from this model, 90% is dog, then the class with the highest probability will be assigned to this image. So and then the model correctly identifies this image as a dog. And those probability values for all the different classes will sum up equal to 1. And image classification has been widely used in clinical and medical imaging. So for example, during the COVID pandemic, there have been many research, to improve the screening and the diagnosis of COVID-19. Here I'm showing an example that the AI model takes an X-ray image, 2D X-ray image of the lung, and can automatically assigns classify a patients into 4 different categories: COVID-19, viral pneumonia, lung opacity, and healthy. So the state-of-the-art AI models can achieve the accuracy as high as 99% for diagnosing COVID-19 cases. So this can be used by clinicians as a very easy to use and a quick diagnosis, because the imaging of X-ray is in seconds. So this can be used as a very good screening and diagnosis tool for COVID-19. Another example of image analysis we do all the time is called image classification. Image classification divides your image into multiple different regions, so that pixels belongs to a similar class will be assigned, will be grouped together. Taking this image as an example, I have an image input my AI model, which can automatically group, for example, people all together, assign the exact same color, meaning they have the same class, and the bicycle. For this example, we divide the image into 3 different classes: people, bicycle, and background. So medical image segmentation has been widely used in medical imaging. It can be used to measure the volume, the size of your object. For example, it can be used to do image fusion to guide a surgery. It can be used to localize analysis in the regions of interest, and etc. It has so many different applications. It's one of the most fundamental tasks in medical imaging. Here I'm showing you one example how we're going to use medical imaging to improve the treatment of patients with prostate cancer. Here I have 2 models. One model is used to segment the prostate gland on the MR image. As you see here, this is input, this is output. Another model used to segment the prostate from an ultrasound image. And during the treatment, we will only have access to the ultrasound image, and then we need to fuse the MR images with the ultrasound image. So we first outline cancers on MRI, and then we need to project it to ultrasound image to guide the biopsy and diagnosis of cancer. So image segmentation really helps to improve the accuracy of this fusion process and to improve the accuracy of biopsy performed by the urologists. Another fundamental task that I'm very interested in is image registration. So image registration, by definition, is that we want to find the point-to-point correspondences between two images. Here, in this example, for example, this pixel of this ear will correspond to another pixel in another image of the ear, and the nose correspond to nose. Basically, in other words, you want to find a geometric, so this image to this image, you apply a geometrical transformation. So in other words, image registration, the goal is to find one-to-one point correspondences, find a geometric transformation that defines one-to-one point correspondences between two images, so that when we apply this estimated geometric transformation to deform one of the image, it will completely overlap or aligns with another image. So image registration, I have developed some image registration methods that can be applied to improve radiation therapy for lung cancer patients. So here, taking this picture as an example, those lines, contours with different colors represents the dose, the amount of dose we plan to deliver to this lung cancer patients. So here is a tumor. Apparently, like when we deliver the radiation doses to kill cancer cells, the location of the tumor will have the highest dose. And those other regions will have lower and lower dose. So the one critical thing for this dose treatment planning is to avoid irradiating like the other lung and the heart and those critical organs, but meanwhile minimize the damage to the lung. So what we have found is that those lung tissues that with higher ventilation, lung is for gas exchange. So those tissues has higher gas exchange are more susceptible to radiation damage than regions with lower ventilation. So what we do is that we apply image registration to register. So we basically have a 4D CT, four-dimensional CT image. It's basically a 3D CT image along with the breathing cycle of the lung. So by doing image registration, we find point correspondences between all those lung pixels. This allows us to first keep track the motion of the lung. And in another way, we can also calculate the ventilation. So the Jacobian determinant of those estimated transformations represents the local lung ventilation, the lung volume change that quantifies the amount of ventilation. So by doing image registration, we compute the Jacobian of those transformations, which represents local lung volume change. And during the radiation therapy treatment planning, we want to optimize the directions, the intensities of those radiation beams, with the goal to avoid irradiating those high ventilation regions, or another way we call those high functioning regions. And those are calculated by image processing or image registration of those 4D CT data. Yeah, this is another example of medical image analysis that we apply to help to improve treatment planning for patients with lung cancer. Next, I will briefly walk you through the idea of convolutional neural networks, which has been applied to extract local, but both low-level and high-level features from those medical images for the follow-up medical image analysis tasks. Traditional artificial neurons, you can consider as an analogy to biological neuron, where for each neuron has multiple input to the neuron. And the output from this neuron will be linear combinations of those input. And so by connecting all those kinds of neurons all together, and then we can model a very complex function. Here, this is another example, another more detailed analysis. So the input to your neuron, you have linear combinations of your input, but usually we'll have a bias term so that we can shift the signal to the left or right, positive or negative. So we have more degrees of freedom. And the output from this linear combinations of those input usually fed into a activation function. So this is the activation function. This is the widely used one. It's called Ray rule. For negative values, we assign 0. For positive values, it's just identity map. So the reason we have those activation functions is to add more non-linearity to the network. Otherwise, if you don't have these activation functions, no matter how many linear layers you have, it's equivalent to only have one linear layer. And therefore, the degrees of freedom you have in your network is low. So having those activation functions really helps to improve the complexity of your model, so that you can model much more complicated like a process, those functions. One of the widely used is the fully connected layer, where the output from each previous layer is connected to all in the input to all the follow-up neurons. So fully connected layer is widely used for image classification tasks. But this idea just doesn't work for images, because images often has, say, for 2D image, 512 by 512 pixels. For 3D image, you have 512 by 512 by 512 pixels. So you have millions of pixels. But if you simply like do what you usually do for the fully connected layer, you flatten them with even one hidden layer. For example, with 8 neurons, this is the simplest like deep learning model you will ever see. So in reality, we have much more complicated architecture. But even with this very simple architecture, you have 6 million trainable weights. So this doesn't work because it makes your model really, really complex. We know that if the model too complex and you do not have enough trained data set, very often you would have overfitting. And not just that, is increased complexity of the model. But if we flatten all those pixels, we kind of lose the local correlation between like nearby pixels. So because those nearby pixels, they should have higher correlation and the intensity are very similar. So by directly flattening it into vector, you lose all those kind of correlation. So which is not great, which is not great feature extractor. So, but instead we apply convolutional neural networks. And we have a stack of convolutional layers to extract lower level features until high level features. So for example, this is the first layer of a convolutional neural network, and that we're able to extract edges from the images. Say you can apply a 3x3 filter with the weights -1 on the left, 0 on the right second column, and 1 on third column. So this allows you to extract the vertical lines, and you can have a different filter extract the lines, edges in different orientations. So usually you have multiple convolution layers for the first layer to extract those features, edges from different orientations. And then by a combination of those edges, you can have your ears, eyes, nose, and for the second convolution block. And the follow-up, if you go deeper, by combinations of those edges, nose, eyes, and ears can come up with your face. So this can be a typical network for face recognition from the 2D images. So convolutional neural networks has the benefits to extract those local image features, but all those weights will be shared, unlike the fully connected like convolution, fully connected layers, where each pixel assigns one unique weight. But for convolutional networks, all those like the filter weights will be shared across the whole image, which makes it really, really efficient. So we significantly reduce the size of the network by doing convolution. But meanwhile, since there are local operations, so we are able to learn the local correlations between pixels to extract those local image features, which are from low level to higher level, which are useful for my downstream tasks. So for essential blocks, for convolutional networks, you have a feature extractor by convolutional neural networks, and then you have a pooling layer usually, because when you apply convolutional networks, it does not change the size of the image if you make the stride equal to 1. Usually we have some pooling layers to compress the spatial dimension of my image. But meanwhile, we'll increase the channel dimension. So the pattern usually is that we extract more and more features, but the feature size will decrease as we go in deeper. And eventually we use those higher level features for my downstream tasks. This is a typical, and this is a very classical convolutional networks. It's called VG16. It has 16 different convolutional layers. So my input, for example, this is for image classification for a RGB image, so it has 3 channels. And the input image size is 224 by 224. So what do we do for this VG16 is that we first have two convolutional layers to extract 64 features from my input image, and then I apply max pooling to decrease the image size, and then you continue this process. So the trend is that we will continuously decrease the spatial dimension of my image, but also meanwhile we increase the number of channels in my input images. So we have more features. So those are visualizations of those features. As you see, those features are lower resolution in terms of spatial resolution. This is the input, and those are features. But we have so many different features, and finally we flatten those features and have a combination of those features fit into a function, which is a fully connected layer, to classify this image into one of those classes by using those high-level features. And this is another example. So if we have a pre-trained previously VG16 network, trains on millions of pixels, millions of images, we can do some transfer learning, which means that we just grab the weight for the convolutional neural networks and as a feature extractor. And those features will be connected to a fully connected layer that for binary classification to classify a chest X-ray into COVID negative or positive. So this types of network can have accuracy at least like 98 to 99%. Yeah, another classical image segmentation network is called a UNet. This is the most widely used architecture for image segmentation. So basically, it has an encoder in that encoder and another decoder. So for the encoder, it extracts high-level image features as it go deeper and deeper, but the image size, feature size become smaller, and you have more features. And for the decoder, then we upsample those high-level features to recover the same dimension as my input. But those are the features that represent the the pixel level segmentation of the images. And also we have those skip connections, because when we go deeper and deeper here, we kind of lose those spatial information. So that's why we need a skip connection to borrow some of those lower level features from my input image to improve the details in my segmentation. And so this network is really good at image localization and segmentation tasks. And the next, I would already go to have a demo of several studies from lab to show you what we are doing using AI for medical imaging. And the first study is a study on process segmentation. So in this study, we propose a method to automatically segment the prostate gland on micro-ultrasound images. Let me briefly give you some background of this study. So currently, the focus is prostate cancer. It is the most diagnosed cancer in men in the United States. So about 1 in 8 men will be diagnosed with prostate cancer during his life, life. And this is also the second leading cause of cancer-related death, just after the lung cancer. Current diagnosis of prostate cancer, early diagnosis of prostate cancer is really important. It can significantly improve the 5-year survival rate from almost 30% to 99%. So early diagnosis is the most important to save life for prostate cancer. So the standard diagnosis is prostate biopsy. So what it does is that you take about like 12 to 14 biopsy cores from the prostate and put it under a microscope and to tell the grade and grade and of those tissues, and to confirm if a patient has cancer or not. And this systematic biopsy is not great because it only random sample like 1% of the prostate. It may lead to underdiagnosis and overdiagnosis. So a better approach is that we first take an MRI imaging of the prostate of the patients, and then we let the radiologist to outline suspicious cancer lesions on the MRI. And after that, when we do the biopsy, what we do is that during the biopsy, we can only do a conventional ultrasound, which cannot distinguish between cancer and non-cancer tissues for the patients. What we do is that we have a live image fusion tool that automatically maps those radiologist outlined cancer lesions from MRI onto ultrasound, so that the urologist can target those regions most suspicious for cancers by determined by the radiologist. So this method is currently the most accurate method for diagnosing prostate cancer in the United States. But MRI is not widely used for several reasons, because it has a very high cost. It's about like $2,500 per scan. And second, to read those MR images, we really need to well-trained radiologists. But we have a shortage of those qualified radiologists to read MRI, especially in those like community hospitals in the United States. There are about like more than 80% of the hospitals in the United States are community hospitals where usually they don't have those qualified radiologists to read those MRIs. And also another potential error is coming from the fusion. So because this is a two-session process, you first do the MRI, and when you do the biopsy, you need to fuse MRI with ultrasound, which is a challenging task that prone to errors, which contributes about 50% of the diagnosis errors in this MRI ultrasound fusion guided biopsy. So in this study, we are investigating a new technology, which is called microultrasound. It's a ultrasound technology that operates at a higher frequency, which offers a 3 to 4 times higher resolution compared to conventional ultrasound we are using. And some preliminary results studies already show that this new imaging modality actually provides a comparable, similar diagnosis accuracy compared to MRI, but the cost is only like 1/10 of that of MRI. For those reasons, so one of the main focus of my lab is to develop AI methods to improve the detection and of prostate cancer on microultrasound. But the first step is we need to outline the boundaries of the prostate in order for calculating the volume of the prostate, and for the urologist to target the exact location of the cancer lesions. But there are some challenges in this prostate segmentation on microultrasound. First, because the radiologists and the urologists, they are more used to read MR images, which are acquired in the transverse plane or the axial plane. But the microultrasound, they are acquired in the oblique plane from the left to the right. And second, there's some indistinct borders, for example, between the bladder and the prostate. And manual segmentation clearly is very time consuming. It takes us about at least like 2 to 4 hours to segment the the whole like microultrasound image sequence per patient, which is not possible. For those reasons, at this moment, like the adoption of this new technology among the urologists is still very low. Most people still prefer MRI. So we would like to develop automatic segmentation methods to improve the adoption, among the urologists. So for this one, we have a team that we have 55 patients, and for the training, and another 20 patients for the training of a deep learning model to automatically segment the prostate gland on microultrasound. So I will skip the details of those data annotation, but this is the architecture of our network. Basically, if you have an input image, prostate image, and then we have those convolutional networks and another network we call vision transformer. So the difference between vision transformer and convolutional networks is that convolutional networks are very good at extracting local image features, and vision transformers are very good at extracting global image features. So our design is to extract both global and local features from the images for image classification. And another innovation in this architecture is that but typically people only care about the final output, but for us, we are doing a multi-scale deep supervision, meaning that we would like the network to input the output segmentation map at different scales and compare with the ground truth. We found that those two innovations really help to improve the quality of the segmentation. Another innovation we have here is that we redesigned the traditionally used binary cross-entropy loss for image segmentation, and we call this new loss as annotation-guided binary cross-entropy. So what it does is that it takes the difference between the non-expert annotations and the expert annotations. So the difference between those two types of annotations tells us the locations where it is more challenging to segment. And we designed our loss function so that we will pay more attention to those more challenging to segment regions during the training, so that the model will perform better on those heart segment regions, so that to improve the performance for those heart cases. So this is a brief comparison of our microultrasound network with the current state-of-the-art method. So as you see, we have better dice coefficient, which measures the overlap between the ground truths and their prediction. Higher is better, 0 to 1. 1 is perfect. And also, we have performed another study that we actually compares our AI model with a human annotators. So we asked a master student, a medical student, and a urologist who has plenty experience treating prostate cancer patients, but only have a few months experience reading those microultrasound images. As we can see, for those folks who are not familiar with the microultrasound images, even just after like 20, I think 20 hours to a week of training, then the performance is not as good as our AI model. And those are some like qualitative results. The ground truth is, we use the green color as the ground truth, and those are the predictions. So we have 3 different patients. Each column corresponds to each patient, and this is the prediction. So we overlay the ground truth with the prediction to show you how good each model. So this is UNet until our model are. So for the first patient, as we see, all the models performs really good. So our model is kind of the best. But for the second and the third patient who has more artifacts, those artifacts are caused by calcification of the prostate. So when the image has more artifacts, as you see, like those convolution-based methods are not robust anymore, and those transformer-based methods are much more robust. And our model, by training the model to pay more attention to those hard to segment regions, our model achieves the best results compared to another vision transformer-based method. So we published this paper in the journal Computerized Microimaging Graphics. And so the first author is a PhD student in my lab. This was his work when he was a master student in the lab. So I will go to a second study we did for prostate cancer, which is radiology pathology image registration. So the motivation of doing this study is that we want to develop methods to allow early detection of prostate cancer on this new microultrasound imaging. As we know, like the early detection of the prostate cancer really improves the 5-year survival rate from 30% to roughly like 99%. So this is the key, early diagnosis. However, we do not have the ground truth, right? For microultrasound image, I don't know the ground truth location of the cancer location on the microultrasound image. But what we do is that for those patients who has surgical removal of the prostate, and then we have their prostate and we section them into several slices and put it on the glass slide for the pathology imaging. So those pathology images of the prostate, they are considered to be the ground truth imaging modality to identify the locations of cancer. So what we do is that we need to do image registration to correlate, spatially align those 2 types of modalities, so that after the registration, we can map the cancer outlines, so-called the most accurate cancer outlines from pathology image, and then map them into the microultrasound image. So by having those microultrasound image and the cancer outline pairs, and then we can train our AI model for automatic detection of prostate cancer on microultrasound. So I will skip this. I already discussed the motivation. So for this data set, we have 18 patients who underwent radical prostatectomy, which is a surgical removal of the prostate, because the urologists consider they have a high grade. This is done for patients who has already confirmed with prostate cancer and then the high risk of the cancer growing outside the prostate. And for each patient, we have microultrasound images. They are acquired in the oblique plane from the left side to the right side of the patients. And those histopathology images, which are cut in the axial plane from the top to the bottom of the patients. And so the first step is to reconstruct image reconstruction, because ultrasound images and the histopathology images, they are required in different different orientations. So our first step is to convert those microultrasound images acquired in the oblique plane into what we call the axial plane. So we have developed an algorithm to automatically do this reconstruction. So you have a sequence of microultrasound images and then reconstruct in the 3D microultrasound image volume to extract those axial microultrasound slices for the registration with the histopathology image. So we design our image registration network as a two-stage. So the first stage is to estimate a more like a global affine registration. So affine, you have rotation, scaling, in translation, etc. Since this is a relatively easy task, simple task, what we do is that we use the process segmentations as the input to my network. So we have ResNet to extract features, and then we flatten them, and we fill them in FreeConnect layer to predict the parameters for my affine transformation. Since this is a 2D transformation, affine transform matrix has 6 degrees of freedom, 6 parameters to estimate. Once we have a very good prediction of this transformation, and we will deform the histopathology image mask so that it aligns with the mask of the microultrasound image. So taking this affine transformation as an initialization, then we design a more complex UNet-based registration network to estimate the geometric deformation between those two images. And then by doing so, after I have an estimation of a deformation field, I can apply this deformation to deform my histopathology image to have a more accurate alignment between microultrasound and the deformed image. Some quantitative results. So we manually label those landmarks between those two images. And after the registration, the landmarks corresponding to each other should be spatially aligned, which means the distance between those corresponding image features should getting smaller. And the mean landmark error after the registration is 2.8 millimeters. This accuracy, I would say, is very good compared to previous studies on MR histopathology image registration. And also, we also measure the overlap between the process segmentation on both the ultrasound and the histopathology image. This high dice coefficient also demonstrate the accuracy of the alignment of the process boundaries by our registration network. So this give you some show some visual results. This is the model before the registration. We want to apply geometric transformation to deform it into this image. So now this image aligns much better with my microultrasound image. So this before registration, after registration, and after the registration, so we can map the cancer outlines on the input image and map them into microultrasound image. So we have, for each patient, we have a sequence of microultrasound image with ground truth cancer outlines. And we will use those results and this data set to train deep learning models for automatic localization detection of prostate cancer on microultrasound image. Yeah, we published this paper in the Journal of Biomedical Signal Processing and Control. So this paper was led by a postdoc in my lab. So next I will discuss another study, which is not prostate cancer. It's type B aortic dissection. So aortic dissection could be a life-threatening disease, and our goal for this project is to predict the progression of aortic dissections and to inform the clinicians to take proper actions. So at this moment, there's no official guideline or no data to guide the choice of the optimal optimal treatments for patients with aortic dissection. But if we could develop an AI model that can predict the progression of the disease, it will be really useful information to help the clinicians make a better decision for the treatment plan. So for this project, the first step to make that happen is we want to segment the different zones of the aorta from a 3D CT image. So that after the segmentation, we segment the different zones of the aorta, then we can measure the diameter, the volume of the aorta at different zones. And this information is critical for the surgeons to make their treatment planning. For example, at this moment, based on the American Heart Association, for any aorta that has a maximum diameter greater than 4 millimeters, then they will recommend a surgery. But this recommendation is not that great because usually those diameters are not measured in the perpendicular plane, but instead they measure in the axial or sagittal plane, which does not reflect the true diameter, of the aorta. And another thing is that they only have one measurement of maximum diameter, but different zones, they grow based on our finding, they grow at different rates. So it's better to have a zonal level estimate of the diameter of the aorta instead of only have a single estimation. I will skip those background. We already discussed them. And so essentially, have a zonal measurement of the volume and the diameter of the different zones of aorta is essential for our treatment planning and for developing our prediction AI model as well. So in this study, we have 59 computed tomography and angiography. So those are used to enhance the contrast in those aorta regions for us to better target the location of the aorta. And we have a team to manually annotate the aorta at 14 different aortic zones. So this annotation is really a time-consuming task. It took us about at this moment about 10 hours to annotate one CT scan. So it take a while to prepare this data set. So basically we have this data collection and then we do the data annotation as a team. And then we partition those CT images into training and validation data set. And the next step, we develop our AI model to do the prediction, and then we compare the prediction and the ground truth. So this is a brief overview of the architecture of our model. To summarize, we have an encoder and a decoder. So the encoder extracts high-level features from the image, and here we have an innovative CSWSA network, which is basically a local context-infused swing unit, swing transformer. So for this swing transformer, it's compared to the original vision transformer, it's known for its computational, computational efficiency for those shifted window attention compared to the global attention by the vision transformer. So we leverage the swing transformer and design our own. So we also modify the original swing transformer. So we update the patch partition component in that swing transformer to improve our the performance. So this is the visual results we have input, and this is a prediction by our model. To summarize the results we found is that our model did a pretty decent job. So we have average dice coefficient of 0.73. Average over 14 different zones. And by applying this AI model to all image regions at different zones, we found that over time, zone 4 and zone 5 are those two regions that grows so fast. And also we leverage this tool to identify the patients with rapid growth and no growth, and this information will be used by us to train a follow-up and AI tool to automatically predict the growth of the aorta zones and by using the CTA image plus non-imaging clinical data to predict the progression over time. Yeah, this paper has been published in the Journal of Vascular Surgeon. So this is a collaboration between me and Dr. Cooper, who is a vascular surgeon, led by a clinical fellow and my postdoc. Okay, next I will discuss a few studies that currently are under review. And so for this study is also an image segmentation problem. But this is different from the problem we have already presented, which are 2D segmentation, and another is 3D. So this is called a 2.5D segmentation. So 2D segmentation is clear that if your object is 2D, you apply 2D segmentation. If you are 3D and you have a high resolution in 3D, then you apply 3D segmentation. But for some of the data, it's 2.5D, meaning that they have very high resolution in the 2D plane, but the distance between those 2D slices are large, making them not truly 3D volume. So then we apply 2.5D images. So those 2.5D methods, they are good at achieving high accuracy, but meanwhile maintain the computational efficiency. So for this data set, we evaluate on 3 different 2.5D MRI segmentation data set for the brain, multi-class segmentation of the brain and the ventricle, and then the multi-class segmentation of the prostate, and for 4 different classes, and the single class segmentation of the prostate. So all those images are 2.5D because they have a high resolution in plane, but the through plane resolution is much larger. For example, this MRI in plane is 0.5, but the distance between 2 pixels are 10 millimeters. So for those data sets, it's not trivial to directly apply 3D. So we apply 2.5D method. So the idea we have is that we say we want to predict the location of the brain on this MRI 2D MRI slice. What we do is that we take its previous slice and its next slice. So because we found that even for human, for annotating the brain, it's more useful to visualize its neighboring slices. So what we do is that we design a cross slice attention module, so to learn the correlation between the previous slice and next slice with the center slice. And this gives us a better, by learning this type of correlation, actually gives a more accurate segmentation of the brain and also like the prostate. And so those are visual results. So I'll skip all those technical details. So basically the idea is to learn those correlations between adjacent like slices to improve the segmentation accuracy. So this is the ground truth segmentation, and this is our network. As you see, our network has achieved pretty accurate segmentation, but for most of the other methods, they do a lot of under segmentation for the brain. Second row is a process segmentation, which is a easier task. As you can see, most of the network did a pretty good job. But for the third row, which is much more challenging task, you have the urethra and the anterior region of the prostate. Those are very tiny. So our model did a pretty good job. All other models either didn't even segment the anterior region or have very, all under segment the location. By showing those, comparing the quantitative results, as you see, our model significantly outperform current state-of-the-art methods. Yep. So this paper is currently under a review in the journal Computers in Biology Medicine, which is led by a master student in my lab. Next, I will discuss another project, which is generative AI in computer vision. So in this task, we applied the well-known diffusion models. So diffusion models were proposed to generate can generate data by observing a large sample of existing data sets. So for here, the idea of the traditional diffusion model is that you have an image, and high resolution image, and they gradually apply noise to this image, very little amount of noise at each step, but through a very large number of time steps. So you apply little noise, say 1,000 time steps later, that your image will become pure noise. It's not recognizable, and the model will learn a image denoiser to reverse this process. Say you have a noisy image into your the denoiser of diffusion model. What it does is that it want to estimate the noise added to this image to slightly remove the noise. So make the noisy image become less noisier. In this reverse process, we call this the reverse diffusion process, so that you have an input of a Gaussian noise, but gradually remove the noise. Hopefully, you will recover a very high quality image. So once this model is trained, then you can randomly sample a Gaussian noise, and then you apply your Gaussian noise to your denoiser, like say 1,000 different time steps to gradually remove noise at each step. Then you will have a high quality image. As you see, this is a good generative AI model because a random noise will correspond to a random image. But during the training, we'll make sure that this random image, the appearance of this random image will look very similar to your training data set, but they are different. So this allows us to generate data that never exist. But one problem with the diffusion process, as you see, is that it has like thousands of those diffusion process, and it is really time consuming because of the use of this large number of time steps. And the training usually takes about 50 hours for the training, and the inference takes about sort of 1 hour or like at least several minutes. So this really prevents the real world clinical applications of diffusion models. So what we propose is fast DDPM. So diffusion models, one classical diffusion models is called DDPM, de Novo diffusion probabilistic model. So we propose a faster version of the diffusion model, which is called fast DDPM. So our idea is that not to use all those 1,000 time steps. Why not use less time steps? So in this approach, we propose to use only 10 time steps. So by doing so, we found that it significantly reduced the training time to about 20% of the original DDPM, and the sampling time even to 1% of the original DDPM. So this is a simple idea, but that works really well. And we evaluated on 3 different tasks. The first task is on to multi-image super resolution. So this is the general network that can be applied to various image-to-image tasks. So using the same architecture, we tested it on 3 different image-to-image tasks. The first one is the image super resolution. So image super resolution is to predict, for this task, is to predict the slice missing in between 2D slices in 3D to improve the through-plane resolution of my imaging data. And another task is that is CT image denoising. We know that for those CT images, if you give it full radiation dose, it will cause some damage to a lung tissue. So what is preferred is that to have lower radiation dose, but still have a CT. Usually that quality of CT is lower than the full dose, has some noise. Our goal is to apply this fast diffusion model to take the low dose CT as input and to predict the full dose CT. Another task is image-to-image translation. So for here, image-to-image translation basically translate image distributions to translate between 2 different image distributions. For example, you want to translate an image taken in the summer to another image taken in the winter. But for medical imaging, we are interested in transferring between different image modalities or image protocols. So we tested on the dataset that we have an input as a T1 weighted MRI and we output a T2 weighted MRI. And those, so let me show the results for each task. So this is the super resolution task, and those are the slides, and this is the ground truth, and this is the prediction. So the goal is to make sure each prediction will be similar to this ground truth. And visually, like for those images, like this gray area is missing from the predicted images. And this is the DDPM. This is our fast DDPM. As you see, our model has a better preservation of those features and has a very high resolution. And we have also have those like quantitative metrics to quantify the quality of the generated images. So as we see, the higher is better. As we see, our model significantly outperforms existing like a convolutional neural networks based one, and another generative AI is called a general adversarial network, is a very popular network for generative AI, as well as the original DDPM. Another task is image denoising. We have a low dose CT as an input, and we want to predict the higher dose CT. So from this low dose to this high dose. So this is the input, and this is the ground truth. So those are the predictions from a convolutional networks based one, GAN based one, the original DDPM based one. As you see, our model, so this is the fissure of the lung, which is essential to divide the lung into different lobes. And we see our model really preserves so from this image to this higher quality image. So we was able to reconstruct a very clear and sharp fissure of the lung. This will be very useful, for treatment planning and other measurements. But numerically, our model significantly outperforms existing models. And another task is image-to-image translation we tested. So we have a T1 weighted MRI as an input, and we want to predict the corresponding T2 weighted MRI. So this is the input, and this is the desired output. So by visually comparing all those predictions in this area, as you see, our model so some of them are very blurry. So our model is really sharp and preserve the architecture of the brain in this region. And quantitatively, if we compare our method to our other models, so we achieve the state-of-the-art performance. But meanwhile, the inference time, if we compare our methods with the traditional DDPM takes about 22 minutes to do the image-to-image translation for one image volume. Our model only takes 13 seconds. So it's much faster than the traditional DDPM, but meanwhile, it's more accurate. Yeah, so this paper is currently under review in the journal Computers in Biology and Medicine. I have one more study. Let me quickly finish this one, and then hopefully you have some time for questions. Another study we do is we do another. It's called zero-shot retinal image registration. As we all know, like AI, the most widely used AI models, they require a lot of training data set, and they are not generalizable to to images that have never seen by the model. So this motivates us to develop a zero-shot learning. Zero-shot means that you don't even need to give the training examples to a model, but the model will still be able to generalize to apply to data sets that it has never seen before. So we apply this model with a focus on retinal image registration. So retinal image registration is very critical. For example, for tracking the disease progression over time. Say here I'm showing example of the blood flow of the eye of 1 month and 3 months later. And if you could register those to bring them, so after the registration, bring them into the same coordinate system, and then by doing so, we can have a point-to-point correspond comparison, pixel level comparison to track the progression of the blood flow over time. So which will be very useful to evaluate the effectiveness of a treatment, and also to guide the treatment planning. Some challenges in retinal image registration is that there's a large deformation. So the large, for example, I'm overlaying two images, a movie image, a fixed image. Those two images want to align. So there's a big shift between those two images. And also sometimes the overlap between those two images is very, very minimal. And all those makes it really hard to to design a model that is robust. Because those small overlap, large deformation usually leads to overfitting in your model. But sometimes, and this is another example, that you may have a healthy retina, before, but after you may have some pathology in your retina, and then those noise added after you have a pathology really contribute, also affect the accuracy and the robustness of your model. So we have developed a zero-shot learning model that we applied to 3 different registration datasets: color fundus image, fluorescent angiogram, and also another one is called, we call LSFG. Those measures the blood flow of the eye. So for our RecNet, it's a multi-stage registration model again. So we first estimate global affine transformation, followed by a more accurate estimation of local transformation. It's a zero-shot learning. We didn't even train our model with any retinal images. The models are trained only on the color, natural images, but we directly apply to retinal images, and we achieve stable performance across all 3 tasks. Yes, it can be easily applied to various datasets. So this figure shows the architecture of our model. What we do is that we first have images, and we apply latent diffusion models to extract features from my images. And then by computing the correlations, cosine similarity correlation maps between those 2 images, it allows us to identify the point correspondences between those images. And we have designed 2 outlier detectors to remove some outliers in the detected correspondences. So, and once we have those correspondences point correspondences between those images, and then we estimate geometric transformation to deform the movie image so that it aligns with our fixed image. So one metric to measure the accuracy of the registration is called, we use a mean landmark error. So the smaller the mean landmark error, the better the registration. So as you see, for this fire data set, our model has the lowest mean landmark error compared to all other existing methods. And if the landmark error is too big, exceeding a certain threshold, we will consider the registration as a failure. So we have a more than 99% accuracy rate. So which means our model is not just more accurate, but more robust compared to all existing methods. Similarly, for another fluorescent angiography image, you can see that our landmark error is like 3 times smaller than any existing method, with a 100% success rate. So other methods that has really low success rate, because this data set has a very large deformation, and a large scaling and displacement deformations, so make it really challenging. So our model significantly outperform others. So this is a less challenging data set. Our model still achieves the best results, but other models also achieved a pretty decent accuracy results. Except for some traditional approach. So those are traditional approach. They are, as you see, deep learning models are much more robust than traditional approach, because those approaches are very often designed for a specific data set and cannot be generalized to other data sets for the registration. So this is the visualization of for 3 different patients for 3 different data sets. I outlined the color of each landmark. So those landmarks, the unique colors, they're corresponding to each other between the fixed and moving image. So after the registration, we would deform the moving image, shift it to the location so that the location of those landmarks will align with each other. So the closer those pixels to each other, the landmarks to each other, the better the registration results. As we can see, so our model was successfully to estimate the large displacement deformation to shift the moving image to here to align the fixed image. This is an even more challenging task, right? So you need to shrink this image and shift it so that it perfectly aligns with my input image. Same for the other datasets. Yeah, so this paper is led by a master's student in my lab, so it's currently on review in the Journal of Computers in Biology and Medicine. So I have more papers to discuss, but due to second time, so I selected 6 studies from the lab. If you are interested in the more studies, recent studies from the lab, you feel free to go to the lab website, and we have already made some posters for each of those papers. Yeah, thank you.